Good evening and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for the Epilepsy Foundation of Michigan, and I'll be moderating this discussion. And this is our final Learn and Share conference call for 2020. The topic for this evening is Seizure Triggers, Identification and Management. And we're pleased to have as our guest speaker, Dr. Shaila Gaddam, who's an epileptologist with the Henry Ford Comprehensive Epilepsy Center. So Dr. Gaddam, could you briefly introduce yourself and talk a little bit about your clinical and research interests and describe your experience with this topic?
Yes, thanks a lot, Russ, and thank you for giving me this opportunity today with the Epilepsy Foundation. I greatly appreciate that. And I'm actually currently an epileptologist at the Henry Ford Comprehensive Epilepsy Program. I've been at Henry Ford for the last 15 years. I have been working as epileptologist for a long time. I have a lot of experience with a wide range of patients with epilepsy, exclusively with epilepsy. And my main interest is with women with epilepsy. But I have exposure to all a range of epilepsy-related cases.
Okay, great. So can you start by explaining what the term seizure trigger means and talk a little bit about the concept of seizure threshold, and then also how an epileptic seizure that follows a trigger differs from a provoked seizure?
Sure. So first, I want to give a little bit of brief introduction with what exactly a seizure is. A seizure is basically an uncontrolled electrical activity where the neurons will fire repeatedly and randomly. Okay. So basically in human normal brain, there will be two kinds of neuronal stimulation. One is inhibitory, means which tries to calm down the activity of the brain, and excitatory, as the name defines, excites. So these are the two main players which play in the controlling of the brain activity. So in epilepsy patients, what happens is there is an imbalance between the inhibitory neuronal activity and excitatory neuronal activity. So when this imbalance goes out of proportion, in sense, there is more of excitation than inhibition. That's when the individual is at risk for seizures. So the seizure threshold is considered lower whenever there is excitatory activity, which we consider as glutaminergic, when that becomes very high. So for general terminology to understand, the threshold increases when there is hyperactivity of the brain. Its electrical activity gets increased. So that's when it lowers the seizure threshold. And main criteria is the imbalance between these electrical activity. For a trigger, to define a trigger, as a trigger is any event that may predispose an individual to have a seizure. Okay, and some patients can have seizures can occur at a certain pattern or at a certain situation. Okay, so this is very important to consider as a trigger. When can we consider this as a trigger? It occurs fairly consistently, not just one time or twice or as a chance. If it just happens once or twice or as a chance, we would not consider it as a trigger. Any situation when there is predisposition for individual to have a seizure is a trigger, but then it has to occur consistently for us to mention that, hey, this is the trigger for the seizure. How do we identify that? How do we say, okay, this is how it's happening? We have to identify and see a pattern. And whenever an individual has a seizure, try to document and try to focus and see, hey, what are the criteria, at what situation, what timing, and maintain a diary at that time and try to see if there is a pattern. Once the consistency comes, then we can surely say, hey, this is a trigger for the seizure. So that is when you call this as a trigger. And one has to pay attention to the surroundings and situations. That's called trigger. And we mentioned about the seizure threshold. And next thing was a provoked seizure. This is very much important to differentiate that provoked seizure. Provoked seizure is something which occurs with an acute symptomatic seizure, means it is an acute situation, it happens. And it is usually isolated. It doesn't repeat itself. And it differs from a trigger or a seizure. From a provoked seizure is it's usually sudden in onset, and it's shorter in duration, and it has an identifiable cause, always has an identifiable cause. Whereas trigger is somebody in a patient who has a known diagnosis of epilepsy or seizures, then there is a more predisposition for them to have a seizure with certain situation. That's called a trigger. But with the provoked seizure, usually they may not have a diagnosis of epilepsy. This could be just an isolated one-time event or so. And these patients may have no family history. They may not have any history of seizures, or their exam is completely normal, no other workup, everything shows normal. So these patients, we do not treat them or we do not put them on medication. We just treat the cause for this provoked seizure. For example, the patient may come with high blood sugars, first-time non-diabetic patient, and they come with a very high sugars and then they have a seizure. So that is a provoked seizure. Patient does not have any history of epilepsy, and these kind of patients, we don't put them on an anti-seizure medication. So I want you to understand that there is a difference between a provoked seizure. Triggers are already on patients who have established epilepsy. So then we are identifying those triggers. And in which situations you will have those triggers? Mainly when the seizure threshold is low. The seizures which are triggered are usually all appears to be similar to what they have, or sometimes they can be a little more aggressive than what they have. So that's the take-home message I want everybody to understand. Yes, they can be a little more aggressive because these were triggered by some situations, and those conditions will get to what are the triggering situations. So those kind of seizures are a little more aggressive than their baseline seizures in some cases. Yes. Okay.
Oh,
now,
okay.
Going
Yeah,
back,
that's interesting. I did not realize that the triggered seizure might be a little more severe.
Aggressive, yes. In situation, and depending upon what are the triggers like and how many triggers were there. If there are multiple kind of triggers, then yes, definitely they are much more aggressive and they may be a little more debilitating than their normal seizures, yes. And for that reason, I want to emphasize that to you all.
Right. Great. That makes a lot of sense. So let's dive right into discussing specific seizure triggers. And we can start with what I've always considered the big three, missed medication, sleep deprivation, and stress. So let's start by talking about medication adherence.
So very, very important information about medication adherence. Yes, that's the number one cause for triggers or worsening of seizures because of medication non-adherence. So it sometimes we call non-compliance. They're not able to take the medication. It can result in a poor seizure control. So there are a couple of studies have been performed in the past that they pretty much say the same reasoning with a little bit of differences. Mainly, first we should figure out why is there is a medication non-compliance or a non-adherence. Why are they having difficulty not able to adhere to the medication? The earlier research showed, which was published in Behavioral Neurology, this is interesting that because of epilepsy, one major reason was forgetfulness. They were not able to remember because of the consequence of seizures and the medications too. They were forgetting. And number two was a concern for the side effects. And number three, people used to believe that they don't need to be on a higher dose. Low dose medication is the only requirement. And number four was comorbidities. If the patient has other medical conditions and they're already taking a lot of medications, so they may forget, and the concern about interaction. So this is one criteria in one of the research they found. And most recently was in 2017, which was published in Seizures. They did a literature review, and they also found that high prevalence of non-adherence was there, was the root cause for recurrent seizures or seizure triggers. So this also found that they had specific beliefs about medications, and number two, people were depressed or anxious, and mostly, number three, they had an uncontrolled recent seizures, so they had more seizures, so they feel like, anyway, it's not helping, I'm not taking it. So that kind of thinking sometimes can do that. And frequent medication dosing, like they're taking 4 times a day. Some medications are 4 times a day instead of 1 time or 2 times. And poor physician-patient relationship too. They may not have able to communicate well or what's going on. So those were also the reasoning. So automatically when we see a non-compliance or a non-adherence, we have to understand, talk to the patient and understand why is that there is a non-adherence. Or this was not mentioned, but I have seen in patients, this is my practical experience, I have seen in patients sometimes they cannot afford and they stretch these medications, you know. So those are also they also play a role. And if we, as a physician, we should sit and talk to them and understand why there is an adherence, non-adherence, because it's very important for them to know that they have to take the medication as much as possible every time, every day as prescribed and at the regular times, because they can have consequences of recurrent seizures or worsening of seizures if you miss a dose or something like that. So I would say first, understand where they're coming from, then we can educate the patients about it. Next, once if they, for some reason, they miss the dose, depends upon what kind of medication it is. If it is a shorter duration or it's a longer duration, and how long, how many times are they taking. If they remember that they missed a dose very close to what they were supposed to take in a couple of hours or 5 hours, they can just take it right away when they remember. But if they remember the dose that they missed it and they remember it at the end of the second dose, they can take double the dose at that time. As long as they do not have any other side effects, because sometimes patients can experience these symptoms of seizure-like activity coming on, then you don't have to wait. So it is pretty much more like individualized, but the take-home message is if it is closer to what they were taking in 5 hours or so, you can take it, or if it gets closer, you wait until the next dose and take double the dose what you missed in the morning hours. That's one thing. And what else can you do other than educating the patient and make them understand? What other options do the patients have? They can use other equipments as devices, like pill boxes are very helpful. Number two, they can use this. Nowadays you have smartphones and you have alarm system, and somebody else in the family members can monitor and make sure they take it. That's another way too. It's not always possible, but at least somebody to check on if it is, that would be of a great help. So this is how we can address the medication non-adherence with anti-seizure medication.
Right. Are there instances in which you've noticed that someone is struggling because of the sheer number of doses of medications, either anti-seizure medications or other medications that they may be on, where simplifying the drug regimen, trying to reduce that number of doses can help? And what do you see a particular role of extended release formulations, which are once daily? Does that sometimes help as well in those situations?
Yes, definitely. That's a good point. Definitely, the dosage does play a role. A number of pills they take in a day. Usually, we have noticed that there is a lot of more compliance and adherence if they take probably 2 pills per day instead of 4 pills, or even 1 pill per day instead of 4 pills or 3 pills. So in these criteria, the extended release medications would be more beneficial. And most of them are coming, most of the newer medications are in trying to help for the patient with the extended release ones. But sometimes there are some medications we are okay to give, even they are about 2 times a day pills. We can give them all at night time, depending upon what the patient's seizure frequency is and what the variation is due, diurnal variation, like if they have it all at the daytime or at night time. So we can try to help and adjust our medications depending upon patient's individual seizures. But reducing the number most likely would be helpful, and increasing the compliance, yes.
Right, right. And as you mentioned earlier about seizures that are a result of a trigger sometimes being more severe or aggressive, is it also true that with missed medications, like if you kind of stop taking medication suddenly, and that are you at increased risk for status epilepticus in those cases?
Very good point, Russ. Definitely. This mainly happens with somebody who has been, who have underlying other neurological issues. If somebody had those, on top of it, they missed a dose. Those kind of patients will have an increased risk for going into status epilepticus, yes. These patients, we usually see if they miss it for a day or two, it's okay. Sometimes they miss it for a week, those things which would be much more difficult. It depends upon how well controlled the seizures were. If somebody who seizes almost frequently, daily basis or a weekly basis, or somebody who seizes once every 3 months to 6 months, the chances of them also is less likely compared to people who have been seized frequently. So right. Yes, and those kind of patients are at a higher risk for going into aggressive status patients too, yes.
Okay, great. Why is it so important for patients to be honest with their neurologist about any difficulties that they're having with medication adherence?
Yeah, I think that's very, very important. The physician and patient relationship is very important because that's very crucial. If they are honest with, and actually we understand the reasoning behind why they are not able to take the medication, once we know, we can actually help them. It may be as simple as, I'm worried about my side effects. I don't know. Then, yes, we are here to help you and try to analyze and see risk to the benefit ratio. Okay. Is the risk of having a seizure higher, or is the benefit of taking the medication even with the side effects is better? So that we can discuss with the patients very openly. If we do not know, and if they're not telling, and we assume that, hey, they're taking the medication and they're still seizing, or then that situation we may think like, okay, we may have to add another medication. But we do check the levels though. We do check the levels, but I want to everybody to understand that checking the levels sometimes can be a little more tricky in sense. Very rarely we have seen patients, even though they take the medication, they are hypermetabolizers, and the levels will still show low. You see, it's very rare though if that doesn't happen. Mm-hmm. Most of the time, it will show how much ever you take it. That's what it is in the system. So that's why it's very important for us to know what is the reason behind that. Being honest is very important, and what's the reason behind it. Sometimes it could be as simple as not able to afford, or then we can help them and say there is a patient assistance program. We can give them some help regarding that and direct them in the right direction, So
Right.
this is
Right.
very crucial to have an honest, open relationship and able to know what's the reason behind the non-adherence. Yes.
Right. Okay. So sleep and epilepsy is a very complex topic, and we've had actually a couple of Learn and Share conference calls on that topic alone. But seizures and treatment side effects, associated depression and anxiety disorders, and associated sleep disorders can all interfere with sleep quality and quantity. And then this in turn can lead to more seizures and also a worsening of mood and cognitive function, and those can all conspire to exacerbate stress and medication non-adherence. So there's this whole vicious cycle with sleep and seizures and stress, and they're all very interrelated. So can you start by explaining why and how sleep deprivation lowers the seizure threshold?
Yeah, as you said, it's very important to know it's like a vicious cycle. It doesn't know which one started which one. You know, is it the seizure and the stress cause the sleep deprivation and stress cause the seizure. So it continues into a cycle, as you mentioned very well. And it also depends upon individual sensitivity too, and also the type of epilepsy also plays a big role in these patients. So there is no clear known cause for why sleep deprivation does, but we have seen the evidence that with sleep deprivation there is increased electrical activity, evidenced by EEG also. There is excessive cortical excitation. And for that reason, this will reduce the seizure threshold and then consequently results in seizures. In my experience, mostly when I have seen patients with a single night of poor sleep or a cumulative effect of poor sleep, which is considered to be insufficient sleep syndrome. Did I see major differences between these kind of patterns? Yes, and it depends upon, again, the patient's individual sensitivity. But in my experience, if there is an acute sleep deprivation patient, especially I see this in specific kind of syndromes or epilepsy, most commonly more sensitive to people with genetic generalized epilepsies. And in reality, in practice, we see this more often in young teenagers or college-going students who try to, especially during exam times, they do this acute studying and they don't sleep for nights and they're under stress too. And those kind of patients will have much more effect on seizures than the cumulative effect of poor sleep, like insufficient sleep syndrome. In my experience, that's what I have seen. With an acute sleep deprivation has more detrimental effect than a cumulative poor effect. But there may be patients who are sensitive to even for that. But I've seen patients with cumulative poor sleep patterns. They have mostly have poor concentration, poor memory, and sometimes they can miss a dose and then that can provoke them to have a seizure. So yes, this kind of sleep deprivation can result in worsening of their seizures. But I think you already mentioned that they have done a lot of sleep and seizures, a couple of sessions already. Mm-hmm. But I just want to mention this, that there are a lot of other sleep disorders too, which can simulate like as if there are seizures, like sleep parasomnias can present like that. In that situation, coming to a better diagnosis is important and have an accurate diagnosis to see what is what would be helpful.
Right, absolutely. So can you talk about your typical approach to assessing and addressing sleep problems in patients with epilepsy when you identify that?
Yeah, so basically whenever I see something like that with the sleep problems, I would like to know is that first, as you mentioned, epilepsy and seizures itself can make people have sleep disorders like insomnia. And medications also can do that. They can cause either disruption of sleep cycle. Some of the medication can cause insomnia or hypersomnia. And also epilepsy seizures per se can result in psychosocial factors like anxiety and depression. So these all can play a role. So when I see a patient with sleep deprivation and causing this, I would like to understand what was the event, under what situation. I will talk to them and try to get information, and then educate the patient, especially with a genetic generalized epilepsy. Their sleep deprivation plays a significant role, and also in a temporal lobe epilepsy seizures also particularly can present with these kind of seizures, worsening of their seizures. So educating them and informing them about sleep hygiene, which is very, very crucial for better control of seizures, especially, and making them understand that how this is a cycle. So teaching them about that and informing them that what are the sleep hygiene, what are the sleep techniques I would tell them. I would say exercise regularly during daytime and not to exercise 2 to 3 hours before. Avoid exercising before going to bed. And it's important to follow sleep schedule. Consistently do it. Wake up at the same time, sleep at the same time as much as possible. And avoid any stimulants like caffeine or anything which stimulates at least 5 to 6 hours before the bed. And do relaxation technique and meditation. So, and also if they're depressed or anxious, they may need more help with that. And referring them to the right people, to deal with the situation would also be helpful. So that is how I would go about in patients who have an established known epilepsy and seizure diagnosis and who are having these frequent sleep-related issues and provoking them to or having a triggers and having a difficulty to control seizures, yes.
Right. And does a stay at an epilepsy monitoring unit often provide some additional information as to a patient's susceptibility to sleep deprivation? Does that kind of give you some clues as to who might be a little more susceptible?
Yes, more than that, epilepsy monitoring would help us mostly with coming to a diagnosis of if they have other sleep-related issues. Like, for instance, if they have sometimes sleep apnea, we can diagnose that even in patients when we admit them into epilepsy monitoring unit. Yes, we can do that. And sometimes patient may not even know that. They only say, oh, we only have seizures during daytime. Sometimes we can pick them up that most activities during nighttime. And we can tell some of the temporal lobe epilepsies can happen during nighttime and sleep. So we can tell them that, hey, this is the pattern for you. So yes, this will be a lot of beneficial. So there is one more entity called nocturnal frontal lobe epilepsy, which is most commonly occur. Frontal lobe seizures usually occur during sleep and during nighttime. Mm-hmm. So putting in an epilepsy monitoring unit will give a lot of insights into how the seizure patterns look like during nighttime and daytime, and also is it just sleep-related issue, or is it related to seizures, epilepsy having trouble with the sleep? So there is a lot of information we can gather, and it will be a lot of help to the patients to better understand.
Okay, great. So stress is an unavoidable part of life, but it can be managed. So can you start by explaining why and how stress lowers the seizure threshold?
It's a very interesting topic, stress and epilepsy or stress and seizures. It's a complex relationship. It's very interesting to know that this is one of the most common trigger which was reported by the patients. If you ask patients, they will say stress is the number one cause of reported trigger. But I want to be very clear, stress alone doesn't cause epilepsy. okay? But stress does result in trigger. The definitive reason with the scientific evidence how stress results in increased seizures is unclear. But there was recent study which has noticed that it's an indirect effect, like relaxation. If the patients are less stressful, more relaxed, they have noticed that there is decrease in number of seizures. So that has helped people to understand, yes, avoiding the stress and dealing with the stress would be helpful by overall reducing the frequency of seizures. Though it was not very clear in human beings, there was no direct evidence because stress is very variable. For some people, little bit of stress could be less traumatic event, or even a little bit of a disagreement can result in a big stress, or a catastrophic event could result in a small stress. So given the relationship and variability of this, there was no clear-cut scientific evidence that this is the only reason for trigger. But given that they found relaxation has helped, so there is a relationship, definitely. There's no doubt about it. But how this will help them, how understanding the stress would help with epilepsy is more important. And they have noticed that whatever situation is causing stress is the one also causing seizures. So it has an indirect effect. The stress has an indirect way of effect with increasing seizures. Because of stress, they worry, possibly have sleep deprivation, and they miss the medication, and they go into the seizure. Once the seizure comes upon, they're more stressful, quality of life is impaired, and that this goes into a cycle. So it's very important that we address the stress. And also, is there a difference between an acute stress and a chronic stress, an acute event and a chronic stress, and positive or negative stress? Not a significant. They have not found major significant difference regarding this type of stresses. And also they have done, recently they have done studies in Cincinnati Hospital where they have noticed, that's where they have noticed that most of the patients have reported stress as a precipitating factor for their seizures. And in this study, 88% of them found stress reduction reduced the seizures. So overall, the take-home message is yes, stress can play a trigger. It is not a cause alone. It's like a direct effect. And how do we deal with this? That is the crucial thing. It's very difficult to control stress overall for many people, or sometimes it is unavoidable. At least we can try to reduce it by doing, first of all, addressing what the stress is, under what situations it's happening, documenting it, and genuinely trying to reduce that if possible. And by techniques like, meditation or yoga or exercise, music, whatever works. And even if this is not helping, maybe counseling would be helpful for these patients. So that we are treating the patient as a whole.
Right. So, yeah, even if we don't know what the exact mechanism is behind it, we know that there clearly seems to be a relationship, and so anything you can do to reduce stress is going to help not only with your seizures but also with overall health and well-being. So now some people have focal aware seizures or auras, and others have recognizable premonitory or prodromal symptoms, and that refers to symptoms that can occur several minutes or hours before a seizure. And these can kind of serve as a warning of an imminent seizure. Have you found that the use of relaxation techniques can be helpful in essentially warding off an oncoming seizure when such symptoms are experienced? And I know this is hard to evaluate, scientifically, because you can't know whether the seizure was actually going to occur in the first place, but just anecdotally, have you found that patients have reported being able to do that?
Yeah, exactly. Yes, that's very true. There are, it's a little more complex than straightforward, but then there were patients who see a pattern in that when they see, and especially when they feel the aura coming in, if they relax, if they get out of the situation, like if they know that's happening and it's going to occur in near future, so they calm down, sit at one place, inform their family members so that they feel that comfort. Hey, I'm not alone. I have some help. That would be of helpful too. So yes, by relaxing, it can help these patients, and there are some patients who actually inform us that I am able to control these. That's one way. And second way is what we tell these patients is when you feel that this is coming on and if you feel that it's going to happen, sometimes we use this rescue medication called benzodiazepines, but not on an everyday. It depends upon how genuinely patient is able to document and maintain a diary and say this is a consistent pattern, and if this happens multiple times, they will definitely go into a big grand mal seizure. Then we would inform these patients that, okay, if this relaxation doesn't work and if you are going imminently, if you feel like it is, then we may have some rescue medication. So that's another way of dealing with that. But to your question, can you ward them off with a relaxation technique? Yes. Does that happen to every patient? No.
Right. For some women, hormonal changes associated with the menstrual cycle can act as a seizure trigger. That's referred to as Catamenial Epilepsy. Can you briefly review why this is the case and what interventions might be effective at addressing this trigger?
Yeah, good. Especially more than half of the women with epilepsy report that their seizures worsen during menstrual cycle. And as you very correctly mentioned, it's considered to be a catamenial epilepsy. For that, first we have to diagnose that, like, is that a pattern again? At least for 6 months, we have to watch them and see if there is a specific pattern. Then we'll come to a diagnosis of catamenial epilepsy. And the reason behind why this happens is mostly during ovulatory stage, around ovulation, and this can happen 1 week before their menstrual cycle when it starts. What happens during menstrual cycle? There is a change in the hormonal levels, especially with estrogen and progesterone. So there is a direct effect of these estrogen and progesterone hormones on brain nerve cells. For that reason, why they are so sensitive to seizures, these hormonal changes, because there is an effect on the brain too. What happens is increased estrogen, it's considered to be a pro-convulsant, means it increases the seizures. Okay. Progesterone, on the other hand, it's considered to be protective, like an anticonvulsant. So estrogen, when there is so these kind of patients will have increased seizures during menstrual cycle for 2 reasons. Either there is an increase in estrogen or there is a decrease in the protective progesterone. That levels go down. So that is the main reason why they have this. And what do you do with these patients? Like, how can we help them? One thing, look at their medications and see, is there a room for us to adjust their current anti-seizure medication to see if their levels are less or if there is a room for us to increase? That's one thing. Number 2, we can actually add same like a benzodiazepines, is a short-term drugs, which we can use around the menstrual cycle. Once we know the pattern, the patient will maintain a diary and they will say, hey, around 5 days before I feel and 2 days after my menstrual cycle I have this, or 3 days before and it lasts for about 5 days after. That's when my triggers are, that's when my seizures are worse. So during that time, we actually give another rescue bridging medication just to calm them down. So that's considered to be a benzodiazepine. That's also is in practice, which we can do. So, and sometimes women with epilepsy are also on oral contraceptive pills for protection and everything else. So when they are on those medications, we actually prefer, because sometimes it could be a combination, estrogen and progesterone, we actually recommend them go with progesterone only pill. Don't go with estrogen pill, because there is so we try to inform that to the patient and also inform to their OBGYN to see, are there on anything situations which can make it worse. So yes, adjusting the dose, add an bridging rescue medication like Ativan only for a brief few days around that cycle period, and use progesterone-only pill. In the past, they actually did a study by giving this medication, progesterone-only pill, to everybody with a Catamenial Epilepsy. They had mixed responses, though. But if they are supposed to be on an oral contraceptive pill, progesterone-only pill would be preferable over the estrogen pill.
Right. It is kind of frustrating that the research has been kind of inconclusive about a lot of these approaches, but definitely there are things that can be tried and they may help. So,
you're right.
Yeah. So perhaps one of the most widely recognized seizure triggers is photosensitivity. However, the rate at which this occurs, as cited in the literature, tends to be only around 3 to 5% of people with epilepsy. Can you start by defining photosensitivity, also pattern sensitivity, and distinguishing between the prevalence and clinical significance of photosensitivity on an EEG versus that of actual photosensitive seizures?
Yeah, that's good. So this is very important to understand photosensitivity epilepsy or photosensitive patterns on EEG. They are not synonyms. It doesn't mean photosensitivity patterns on EEG is equal to photosensitive epilepsy. To be calling it as a true photosensitive induced seizures, it's a phenomenon of an actual clinical seizure triggered by strobe flashes, and it represents a true photosensitive epilepsy. The patient actually has to have a clinical seizure with the strobe flashing lights. That is the photosensitive epilepsy.
Right.
But there is, basically this is more common in patients who are with history of genetic generalized epilepsy. This is photosensitive epilepsy is more common in those, mainly in juvenile myoclonic epilepsy. And it's interesting that we should know it's more commonly seen in young, adolescent, and teenage years. And as they become older, this becomes less prevalent. It's very unlikely to have a photosensitivity epilepsy in an adult. Okay. Another take-home message is there is a phenomenon which we see when you say the patterns. Yes. When we do a EEG, every patient who went through a EEG will have a photic strobes going through. That is a triggering. We do a activation procedure. Okay. And most of the time between 5 to 30 hertz, if they have tendency to have a genetic generalized epilepsy, we see abnormality in the brain waves initiated by photic stimulation. So that response, we call it as photoparoxysmal response. What does that mean? Photoparoxysmal response means with photic stimulation, the brain gets hyperactive and it gets excitable, and there is a tendency that this patient is at increased risk for photosensitivity epilepsy. But that does not mean that he has photosensitive epilepsy. Okay? So there's two important criteria for that. Because sometimes you can have this response, that photoparoxysmal response, which we see on EEG with a strobe light stimulation. This response can be seen in patients who have a trait. What does that mean? Patient has a family history of genetic generalized epilepsy, and they may have a trait, and they can have an abnormal EEG. They may never have a seizure. So they are just a carriers, but they don't have a full-blown seizure-like activity like photosensitive epilepsy. So that's why you should be careful when the interpretation says photoparoxysmal response, increased risk for photosensitive epilepsy, doesn't mean that they have. And for that reason, there is the literature says only 3 to 5% because it's mostly in young adults, and it goes away. Only with exception, with two exceptions, I can tell you that. But we can go about in future to your ear. There are some points I can tell you, but I'm going to tell because this is relevant here too. Sometimes alcohol withdrawal seizures can manifest with photosensitivity, and also medications like barbiturates or benzodiazepines who are on there for a long time and they withdraw the medication for some reason, they get very sensitive. Withdrawal seizures can present it like this too. Okay,
Oh, okay.
It's a very it is, but that's the take-home message for this photosensitivity. It doesn't mean that every patient who has that will end up having a photosensitive epilepsy.
Sure. Okay. So in my experience, the percentage of people who perceive that they have photosensitive epilepsy is much higher than the prevalence of photosensitivity reported in the literature. And the specific reported triggers often include photic stimuli that are well outside the generally accepted range of flicker rate. So I hear a lot of people talking about modern fully functioning computer monitors and TVs, or sometimes just bright non-flickering light, or even transitions from a dark room into a light place as being triggers for them. So how do you explain, I guess, this discrepancy between what's reported in the literature and what is reported more anecdotally among patients?
So first thing, it's important that this is so, even though the prevalence is about 3 to 5% in the literature, but given that it is this photic stimulation is so much around with them, currently with, as you mentioned, TV, or even they go out anywhere. So just to be helpful, they inform these people that it is mentioned that you have to be careful. That's one thing. Would that play into a role? I'm not sure. But it would be interesting to see what are considering to an epilepsy. If they're just having the feeling, and is it going into a full-blown seizure? What kind? That will also help us to understand, is it what exactly? Is it a photosensitivity epilepsy, or is it the concept of over-analyzing, or am I anticipating that and I'm going to have it? You see? Could that play a role in this? That could be to some extent, given that it is mentioned, even if you go to a Halloween party or anywhere, there are flickering lights and they mention it. So is that the anticipation going to make you feel that way? Or are you thinking, oh, I'm going to have this? So that could in my experience, I can say that on my behalf, could that play a role? Yes.
Right. And there may even be instances where the anticipation or worry about being exposed to flickering or flashing lights is stressful enough that the stress of that actually it can trigger seizure rather than the lights. Yeah, right.
Exactly.
Okay. For those who are photosensitive, can you talk about the recommended measures to reduce the risk of exposure to photic stimuli and how to respond in instances where you are accidentally exposed?
Yeah, so one of the things, how you can reduce it. So avoiding is the first thing, but I understand it's not completely possible to avoid it. So best thing is try to be farther away from the stimulus, like especially if you're watching TV or anything like that. Sit away from the stimulus, and also don't put a lot of variation in the light, and sense don't sit a big movie watching and you're in a dark room. So when those things come up, so try to neutralize that area. So that would be of help. Maintaining a distance of at least, they say, minimum, don't want to be very close, farther away as much as you can. And also keep your remote control right away with you, next to you, so that if there is anything you feel like, just switch it off. That's one thing. And if you have a trigger, if you know, even after you're going, suddenly you are exposed to it, what the recommendation is to close one eye rather than both the eyes. Doesn't know the reasoning behind it, thinking that because the closed eye, it's a visual evoke potential, you can still send the responses. So one eye is actually inhibiting it. So with closed eye, that's one thing. And turn away from the stimulus. You have to take the person away from the source of the trigger, wherever. And wear the polarized tinted sunglasses if you're going. Even if it's dark, put those on, and if you're going into places, avoiding that. That's one thing. Most important thing is once they are in a seizure already, very crucial that you follow the seizure precautions, laying them flat and turning them on the side, those ABCs of how you take care of seizures. But the very critical thing is taking away from the trigger. As long as they're still on the trigger, you're still stimulating them. So try to take them away from the trigger.
Right. And I remember hearing at one point that actually covering one eye with your hand is even better than closing one eye, because the light can potentially filter through your eyelid. And
Exactly.
Yeah, right.
Yeah, you're very right. You have to cover one eye and go through them rather than just closing. And closing both eyes is equal to just staying there. Okay. And even just turning your eyes, just not looking at the trigger is also not right. Getting away from the trigger is important.
Right. And have you had any patients, relay that they've had success with certain blue tinted? I've heard a lot of patients talk about a particular type of glasses that are blue tinted, the Zeiss lenses or something like that. Has anyone mentioned specific sunglasses that are particularly effective that you're aware of?
Not to my knowledge. Usually covering them, not the blue one though, Russ. I have not heard about in my recent experience with these patients.
Okay.
No, I did not, but that's interesting to see. I will look into it, but in my experience, no, not with the blue tinted one.
Yeah. And the other thing, obviously to be aware of is is that it not only strobe lights, in some cases it can be bold, contrasting patterns like black and white stripes or red and black, right?
That black and white, exactly. The pattern.
It can be flickering light off of a body of water. It can be light flickering through trees. That type of thing can also have a similar flicker rate that could affect that. So just being aware of that as well if you have photosensitive epilepsy.
You're right.
Okay, so now we're kind of going to do a lightning round of sorts to briefly discuss some of the many other possible seizure triggers. So for each possible trigger that I mentioned, if you could just talk briefly about the nature and prevalence of that trigger and maybe some tips on how to reduce or avoid that. So let's start with alcohol. You mentioned that briefly, but can you talk a little bit about alcohol or alcohol withdrawal as a seizure trigger?
Yeah, a very, very common entity with alcohol. Mostly what we see is patients alcohol induced versus alcohol withdrawal. What we see more commonly is patients who have alcohol withdrawal ones, when they drink more than like bench drink and then they come in, they stop drinking and they can have these kind of seizures. About 5% of general population, but 1/3 of patients who are alcoholic can present with alcohol withdrawal seizures. And take-home message is just 1 or 2 drinks on a rare occasion would not induce seizures. But I want to be very cautious. It's not like everyday drinking now. socially, one drink or two in a mild form would not result in a seizure. But definitely if they drink more than 3 or 4 than their usual and they repeatedly or bench drinking and they stop drinking, these are the ones which will cause it cause triggers and increase with seizures. And what kind of seizures these patients will have? Majority of the time, they will have generalized tonic-clonic seizures, which we call them as a grand mal seizures in general terms. These most commonly occur between 4 to 48 hours after the last drink. And sometimes if the patient already has epilepsy and they are on anti-seizure medication and they drink alcohol and they bench drink and they stop drinking, they throw up and they don't take their medication. And it's a combination of those things, the medications and the interaction with the medication, and they stop drinking. So we, in our practice at Henderford, we see a lot of patients who come in this state who are withdrawal and miss their medications, and they go into repeated seizures, frequent seizures. And sometimes they go into status too. So it is very, very, very important to understand, yes, responsibility is very important and how much and who. So alcohol withdrawal seizures are very important to understand that they can cause quite a good amount of effect on the person's physical state. And how do we go ahead.
Go ahead.
Sorry.
No,
how do we avoid this when we understand this? How do we reduce this? Educating the patient again, informing the patient that, hey, there is a responsibility you have to take. In general, as physicians, I have to be very honest. We tell patients don't drink, and once we educate them, they will understand. But in real life, it's hard for them. Sometimes they want to. So then we have to give them that leverage of, hey, you have to be responsible enough not to do this. Probably a one can for every social life, like every few months or so. But as long as they understand, that's important. And avoiding is the best, and limitation is the best. And when they know when to stop is the best thing to do. And not do it is the best thing to do. So, and if they have all these happening, get to the hospital or seek medical attention right away, and we put them on a benzodiazepam. This is for withdrawals. And if they repeatedly do this, sometimes we say, you know what, you are coming into the hospital with status every time. Is it actually beneficial to put you on anti-seizure medication? So it's the very risk to the benefit ratio. I have worked in VA hospitals in the past, so we used to see a lot of them, and it's a very, very difficult scenario to handle.
Right. And of course, if you notice yourself that you're maybe more sensitive to alcohol, and when you have had a couple of drinks that you've had seizures as a result of that, then that would be a good indication that maybe it's best to avoid. Have you found that some people are a little more sensitive than others, or is there variability in that?
Yeah, it is. It is. There are some people who are sensitive, and especially people with genetic generalized epilepsy patients are the ones which are a little more sensitive, for sure. And we have seen this kind of seizure syndrome is mostly during young adulthoods and teenagers or college-going kids, and sleep deprivation is also a trigger, and then alcohol, even little bit of it, so they are sensitive to it, as I mentioned before too. Yes, those criteria happen, but sometimes people understand that they know how their body reacts and they stop. They try it once, twice, if it happens every time, and they know even little bit of alcohol, it triggers. So it is not hard and fast rule. One rule applies to everybody. No, it is your body. It will tell you. There are some patients of mine who have even little bit, they cannot tolerate it, and they try it second time and they could not tolerate it, and they now understand and they don't take it anymore because it's not worth it for them.
Right. Okay. How about other illegal or recreational drugs? I assume there are many different. We don't have time to go into
The,
all of those drugs,
you're
but
right.
just in general.
Yeah, in general, yep, there are a lot of them, but most common ones are, which we have seen in our experience, is cocaine. It does cause you to have it. It increases the risk of seizures, mainly by reducing the seizure threshold. And it also have other effects like on the body with heart attacks and irregular heartbeats, so that's one of the biggest, which we see more often, which is more common, cocaine. Next comes amphetamines, stimulants, and heroin and phencyclidine. Amphetamines are stimulants which are given for ADHD, these kind of patients too, but if they are used in a uncontrolled, under physician control, the chances of them getting in trouble is less likely, as long as it's not that amphetamine alone will cause, but how much are they taking? Are they taking mixing with other things can play a role. So, but these also, any of these patients can manifest with, again, generalized tonic-clonic seizures too. Okay. And sometimes they develop multiple seizures, and sometimes they can go into a status epilepticus. It's independent of how they take it, which route they take it. It doesn't matter. And sometimes acute users, first-time users can also have this, or a chronic users can also have this. And one more thing I want to mention, I know medical marijuana is a big in this. I have seen in my experience, it has a both protective and sometimes as a convulsive effect to in patients. So it depends. So it's a little more difficult to understand that specific drug. Okay.
Right. And I'm guessing just because of Epidiolex being approved that CBD only cannabis products are probably lower likelihood of provoking seizures as opposed or of being a seizure trigger as opposed to those with THC.
Yeah, I think THC, yes, cannabinoids seems to be more protective. But it's as I said, it's an individual. I had a little bit of different experience with my patients, so I don't want to go there.
Sure. Okay. So how about medications for other conditions? There are some medications that themselves can trigger seizures. I assume all epileptologists are well aware of these and will make sure that patients aren't taking them, but other physicians might not be quite as aware of them. So if you can just maybe quickly review some of the top medications that you should avoid.
Yeah, definitely. I would, most importantly, I would educate the patient that whenever they're starting a medication, they should inform that to their physicians that they're on anti-seizure medication, and also check with the pharmacist too. So those are the two criteria I would tell and explain my patients first. Make sure that you proactively be involved. That's one thing. Then next thing is, what are the most common ones which we usually use? Like as simple as antihistamines, like Benadryl. Most commonly it's a generic name, diphenhydramine, chloramphenicol. So these kind of medications can have reduce the seizure threshold most commonly. And antibiotics, most of the patients when they get sick, they can take up medication, and if they're in the hospital, they use. So that's another thing which commonly used. The cephalosporins or penicillins, imipenem or metronidazole or gentamicin. These are the common ones. And what are the other common medication is antidepressants. Also have to be careful with amitriptyline or nortriptyline, fluoxetine. Of that, this fluoxetine is a little better, but other medications like Haldol or Risperidol, those are the ones you have to be careful with. But we always work with the physicians and the patients, referring physicians to the psychiatrist or whoever they're treating. We always have to see risk to the benefit ratio. If they need to be on that, we have to up this dose. There is absolute contraindication is not if they need it, but they have to be cautious that it will reduce the seizure threshold. So we have to increase the other medication. There are instances for anti-cancer, antineoplastic, like cisplatin, methotrexate, vincristine, cytarabine. If they have to be, then we have to watch them and see and tell them and inform them and educate, anticipate and treat them and put them on a higher doses or change the doses. So yes, these are, and other ones are narcotics, which are pain medications which are given. So these are some of the most common ones which you have to be careful about and remember too.
Great. Strenuous exercise. I think we know for most people, moderate exercise is generally not going to trigger a seizure, but for a fraction of people with epilepsy, strenuous exercise may. Can you talk a little bit more about that?
Yeah, there are not specific numbers given for the strenuous exercise, but definitely it may not have a direct effect, but it does have an indirect effect, as we will talk in future regarding the medication with the effect it does to your body. It can cause excessive strenuous exercise, can cause electrolyte abnormalities, and if they are not consuming, usually they say you have to hydrate yourself before going to do a strenuous exercise. If for some reason they don't and they deplete their fluid levels and it can affect their kidneys, and that can result in with dehydration, electrolyte abnormalities. All these can result in lowering the seizure threshold and resulting in seizures, increased seizures. Yes, it's kind of a little bit of an indirect effect with that.
Right. But in general, exercise is for the vast majority of types of exercise, and the vast majority of people with epilepsy is safe and recommended. It's just there may be certain instances where it could, like you said, indirectly trigger.
Indirectly trigger,
okay.
And
How about fatigue, which may be a result of exercise or a result of sleep deprivation, but just when you look at, again, reports of what people say is a common seizure trigger, fatigue is often listed as one. What do you know about that?
Yeah, fatigue is mostly in the, what I have experienced is mostly in relation to either sleep deprivation or physical illness, if they have it. Isolated fatigue alone would not do. If there is definitely in these criteria, I have seen patients having triggers with those fatigue situation, but isolated fatigue without any known underlying cause as individual trigger factor to increase the seizures, in my experience, is less likely.
Okay.
I would not say unlikely, but as less likely.
Sure. So what about transitions between sleeping and waking or between different phases of sleep?
Yeah, that's important. Usually there are some specific epilepsies which are more prominent during these phases, especially as I mentioned, the frontal lobe epilepsies are during light sleep, especially during the transition between wakefulness and going into sleep. Within the first 2 hours of that happening, they can have increased seizures, or when they're waking up in the early morning hours, it can happen. And my juvenile myoclonic or myoclonic epilepsy is much more frequently after they wake up, the first thing in the morning, early morning, they have these seizures. Yes, there are bona fide triggers for that. Once we understand the pattern, we try to change the medication doses and see if we can tweak the medication so that it will help them to avoid these situations. Instead of giving them in the morning hours, we try to give late in the evening so that we can try to avoid these patterns. Yes, that is not uncommon. We see that.
Okay. What about fever or illness? We alluded to this a little earlier, but is that also a common trigger?
Yes, fever and illness is very, very common trigger, mostly because, you are dehydrated. You have a lot of metabolic or electrolyte imbalances. On top of it, you may have other issues like nausea, not able to, because of the illness, you're not able to keep the food inside and not able to take the medication. That is what plays a significant role in these patients if they are sick, illness. We see some of the patients, I have some of the patients who come in because they were not able to keep up with their food intake and the medications, and it becomes a vicious cycle. Like the illness is there and not having the medication too, especially if they have nausea, vomiting, with the GI symptoms if they have. So you have to be careful when something like that happens, informing and letting us know, so that are there any medications which we can give through IV or other means of medications, or they do need to come in and hydrate them and send them and watch them and go. So yes, fever as such and any illnesses, and especially if they have a component of GI symptoms, you have to be careful about them.
Right. Right. Also kind of alluded to this already with dehydration, but it sounds like that's generally a case of that will then result in an electrolyte imbalance, which then can trigger a seizure.
You're right. Exactly.
Okay. Yeah.
Same.
What about overheating or sudden temperature changes? I know that's true for certain specific epilepsy types, but can you talk a little bit more about that?
Yeah, I have seen it's interesting that temperature changes and even seasonal changes for whatever reason. There are some patients who say that they're more sensitive to these kind of fluctuations in the temperature, especially if they have a sudden temperature changes, if it is too much of winter and then suddenly it's a too warm weather, or warm weather, then it gets too cold and then goes warm and cold. These variations can happen. What can you do about this? Until we have a specific pattern, we don't treat these patients. We tell them if there is, try to avoid it, going outside and expose yourself. That's one thing we can do. But we don't tentatively, proactively try to treat these patients with any medications. No.
Yeah, and I've heard of some, parents using cooling vests and things like that can be helpful for kids with specific
You're right.
sensitivity to that. So low blood sugar, or you also mentioned high blood sugar. Are both of those possible?
Exactly. Both of them are possible, low or extreme high blood sugar. Low blood sugar is, do they just present with seizures alone, especially if the blood sugar, if they falls less than 50, with a fasting blood sugar of 70 to 100 is normal, and if they go below that is when they manifest. Usually, low blood sugar, they will have other autonomic abnormalities before. They feel a little bit dizzy, they feel sweaty, and they can have a feeling of uneasiness, and they know something is going wrong, and they pass out too sometimes. But seizures do occur, and they can go into coma too. So depending upon how quickly the blood sugar dropped and how long it is and how low it is, those are all the criteria for the seizures, if they develop seizures or not. Initially is not initially presenting right away is very less likely, but we do see patients, so sometimes the presenting symptom is a hypoglycemia, and plus time they come with seizures, then we consider that symptomatic hypoglycemic seizures. Okay, so majority of the time there is a way the blood sugars drop and the way the patient manifests, but sometimes, yes, they come with the seizures alone, especially in patients who are diabetic and they are on insulin and they get a lot more of medication, and these patients can present with seizures, yes. We usually treat them. We usually tell them if they're having a premonitory symptoms of feeling a little bit dizzy, take a little bit of a sugar candy with you all the time. Carry some sugar with you and go from there. If they get to a stage where they are already went through all this and have a seizure, obviously they will be in a hospital needing to give an IV infusion with this medications and go. But educating the patient that when they are a diabetic and informing them and having a better control of it. Usually we see this low hypoglycemic with a known diabetic on the medications is what we see with seizures, yes.
Right. And it's interesting to note that some of these triggers that we're talking about can also, they can be triggers for people with epilepsy, but sometimes they can also be cause provoked seizures in people without epilepsy, like low blood sugar, like dehydration, like febrile seizures of fever and alcohol withdrawal, for example.
Yeah.
Okay, so certain foods or ingredients. Now, this is, again, a lot more anecdotal from probably. I hear a lot of people who will mention specific foods or ingredients that they have found to be triggers. Have you noticed any that stand out to you that are possible triggers?
Yeah, I have, in my experience, I have seen caffeine. It does trigger a stimulant, kinda, yes. And MSGs, people mention that to some extent. Junk food or any other food, very rarely they have specific criteria and they feel that does happen. So especially in EMU, when they come in, we admit them, we ask from them triggers so that we can try to give those triggers to make them have a seizure. So some of these patients do have a specific criteria, and sometimes they are they do happen that way. But are they very common? No. Most common of these is caffeine and MSGs. We have seen that. The rest of the other foods, like criteria which are specific for some patients, they are sensitive. Even sweeteners, it can happen to them. But that's not very frequent and very common. It's kind of a little rare.
Okay. And then lastly, triggers for specific types of epilepsies called reflex epilepsies, things like reading or math or being startled or even music. Can you talk just briefly about reflex epilepsies?
Yeah, this is an entity which is present for a long time, but it's not that common. It's quite rare. Mostly I have seen with a reading epilepsy. I haven't seen much with, I heard about a music, but startling is something which can happen in patients who have underlying, you see that mostly commonly who have underlying brain damage and who already have a neonatal issues, anything which happened when they were young, with a traumatic brain injury or anything like that, startling response, you can see that. But these are pretty rare. But again, as with any other epilepsy, this also has to be have a consistent pattern. And once you know, you avoid them, and that's the best way. Avoiding the trigger. That's what we tell the patients. Once you identify a trigger, how can we treat? Even if you take a medication and if you still have a trigger, it may make it worse. So avoiding the trigger is the criteria or the most important thing for us, for the patient to understand.
Okay.
If possible. If possible.
Right. Okay, so just given the time, we had a few more questions listed, but I want to make sure we have some time for Q&A, so I'm going to go ahead and unmute all the lines, and I just remind people, please, if you have background noise, please keep your line muted unless you're asking a question. So let me just go ahead and unmute the lines just a moment. Okay, does anyone have a question?
Can you take him to court? Can you say, okay?
Okay. Yeah,
I
I'm just going to remind people. Go ahead.
So my question is what is the connection between epilepsy and aneurysms? I know there's no genetic marker for aneurysms. However, that runs in my family, and my daughter is diagnosed with epilepsy. So I was just wondering how the two are connected, and if she's at a higher risk for having an aneurysm because she has epilepsy, or vice versa because that runs in our family, aneurysm.
So, good question. So, do you have a family history of aneurysms in your family, you said? Is that right?
So, Yeah, so 3 of my
Okay.
great uncles had died from brain aneurysms, and then my aunt just had one on the 25th.
Okay. Okay. And your daughter has been diagnosed with epilepsy.
Yeah, since 6 months
Is that
old.
right?
She's
Okay.
11 now.
Okay. Okay. Good. Okay. Good to know. But I can tell you, it's a reverse way actually. Seizure epilepsy would not cause aneurysm. Okay. Epilepsy will not result in aneurysm. But if the patient has an aneurysm and they rupture the aneurysm and there is a bleed and it caused damage to the brain, that can result in a seizure and epilepsy. Okay. But epilepsy alone, she is not at risk having just because of epilepsy, she is not at risk of having an aneurysm, but because of the family history of aneurysm, there may be an independent risk for her to have an aneurysm, but it is not the epilepsy which is causing her to have an aneurysm. Do you understand what I'm saying?
Okay. Yeah,
Okay.
I do. I just wanted clarifications because
Sure.
there's no genetic marker for aneurysms, but it's in all of our genetics. Kind of. Like, you know what I'm saying? Like, it's coincidental. So,
You're
thank
right.
you.
You're right. But don't
Okay.
worry, I don't think she will have a aneurysm. Okay, go ahead.
Okay. Other questions?
Excuse me.
Go ahead.
My question is anxiety stress. I was recently diagnosed with stage 3 chronic kidney disease, and the anxiety is coming on that I have to have a 1-hour ultrasound, and I don't know how to have them handle it. They told me why I got it, now the symptoms and everything. But the anxiety is now having at the ultrasound, and they want me to lay on my stomach, which I can't because I have a knee replacement. And my primary doctor has given me a prescription for anxiety medicine. And then comes a doctor's appointment, and I just want to know how to deal with this anxiety, and how can I tell the doctors what to do.
Yeah. So basically with anxiety, you already mentioned that your doctor gave a prescription for anxiety to deal with ultrasound. You already got a
Yes.
prescription for that? You did. Okay. There are 2 phases to address this. First of all, to get that ultrasound, you may have to take that medication so that you can get that testing which is required. Number 2, you need more help in sense possibly try the conservative treatment like mechanisms like stress relieving, relaxation, meditation, whatever works for you. If that's not working, maybe it's time you talk to your primary care doctor and ask them, you may need a referral to a psychological assessment or help, especially given the current situation. You can still get help through video visits and they can help you how to address that, because it looks like you need more help than just the medication if it is acting out for you so much and interfering with your activities of daily living.
Okay, just one other thing. Should I go back to my neurologist if I'm still having seizures because of anxiety? I've talked to the Kidney Foundation about it. So should I go back to my neurologist if I'm continually having seizures?
So your seizures are worse now? Is that what I'm hearing?
No.
Is that right?
No, I haven't had any. But
Okay.
if I know that, or I get a lot of pressure in the head, and that lets me know. And then when I'm in it, I got FIA. I have no knowledge of what I've done. Sometimes I have convulsions, but I'm just concerned: am I going to keep having these over and over? Is the medicine going to relax me? And if not, after the ultrasound and then the follow-up doctor, should I go back to the neurologist and have her update my medicine?
Yeah, I think that would be a good way to go with. Go ahead and have your medication and have an ultrasound, but I think keeping in touch, the channels open with your physician is very important. Maybe they can increase the dose, or maybe they can give you an anti-anxiety medication, which will also help you with your seizures. So there is a lot your doctor can do, your neurologist can do with this, yes. And I think keeping the communication open and talking to them is very important.
Okay, thank you.
Okay. Have time for maybe one more question? Okay. Well, I have one more question. Can you just we mentioned a little bit about seizure diaries and the importance of that. Can you talk a little bit about the value of that, of keeping a seizure diary, whether it's printed or whether it's you're using this tracking app or seizure tracking app or website? Can you just talk briefly about why that's so important and how it can be used by the doctor and the patient to better manage seizure triggers?
Yeah. So basically, maintaining a diary is very informative and educational, both for the patient and also physician. Sometimes even patients may not understand. Once they put it in paper and pen or whatever device they want to use, once they document it, they can actually see a pattern. So that's how they can diagnose the triggers too. Once you figure out there's a trigger, you can avoid the trigger and it will help you. So maintaining a diary is very important. One, identification of the risk triggers or the patterns. That's one thing. Number two, the frequency too, to see actually whether the medication is helping you, in which way. So there is a definitive way for it to look at it, say, hey, this is the time this medication has helped and I'm still not making any difference with the medication. So that will give a medication management too. One thing is for educational purposes, you will better understand for the physician and the patient, and also to see the treatment plan. Okay, there are some months they are much more active, or there are some weeks they are active, or some days they are active. So we can personalize the anti-seizure medication regimen along with their seizure diary maintenance. So that is very, very important in management of epilepsy.
Okay. All right. Well, so it is time to wrap it up. So I really appreciate the discussion and all of the great information and suggestions you provided. We covered a lot of ground, so I really appreciate that. And I hope it was helpful to our participants. And thank you, everyone, for participating both this evening and throughout the year. If anyone does have any questions about, or wants some more personalized guidance on seizure triggers, certainly feel free to contact us at 1-800-377-6226. And, of course, you can always visit our website at epilepsymichigan.org. So thanks again, Dr. Gaddam, and thank you, everyone, for joining us.
Thank you, Russ, for this great opportunity, and thank you for all the participants, and hope this was helpful. And if you need any help, always Henry Ford is available. Thank you.